Good day, esteemed colleagues and future dermatology luminaries. Today, we embark on a captivating journey into the intricate and multifaceted world of cutaneous tuberculosis, CTB. Though less common than its pulmonary counterpart, CTB holds a significant place in dermatological practice, presenting unique challenges and profound learning opportunities. Imagine walking through a vibrant marketplace where each stall and passerby tells a story of skin health and disease. In this lecture, we will unravel the narrative of cutaneous tuberculosis, exploring its origins, manifestations, diagnostic pathways, and the therapeutic strategies that empower us to restore and maintain the integrity of our patients' skin. Picture a bustling community, teeming with children playing under the warm sun, individuals engaging in daily activities, and environments ranging from pristine to modest in hygiene standards. Cutaneous tuberculosis thrives in such settings, weaving itself into the fabric of everyday life with a higher prevalence among specific populations. Who are the main characters? Children and adolescents. The energetic youth, with their active lifestyles, often serve as the primary hosts. Their developing immune systems and frequent skin-to-skin interactions create an ideal environment for tuberculosis colonization. Adults with compromised immune systems, individuals battling conditions like diabetes, HIV/AIDS, or those undergoing immunosuppressive therapies become vulnerable protagonists in this narrative. Geographical influences. The story intensifies in tropical climates and crowded urban areas where hygiene practices may falter, providing the perfect backdrop for infection to take hold. Risk factors. The plot twists. Immunosuppression. Conditions such as HIV/AIDS, diabetes mellitus, and malnutrition. Contact with active TB cases, close household or occupational exposure. Previous tuberculosis infection, reactivation or dissemination. Genetic predisposition. Certain HLA types may increase susceptibility. Causative organisms and their arsenal. At the heart of our story lies the formidable Mycobacterium tuberculosis, the primary antagonist in cutaneous tuberculosis. This bacterium is not a one-dimensional villain, it comes in various forms, each with its own set of challenges. Mycobacterium tuberculosis complex, the primary pathogen responsible for CTB, including Mycobacterium tuberculosis and Mycobacterium bovis. Mycobacterium leprae, occasionally implicated in borderline cases. Virulence factors, the weapons of war, cell wall lipids. Rich in mycolic acids, providing resistance to desiccation and many antibiotics. ES86 and CFP10, proteins that facilitate host cell invasion and immune modulation. Granuloma formation, the bacteria induce the host to form granulomas, walling off the infection but also creating a niche for persistence. The diverse faces of CTB. Imagine encountering a patient whose skin tells a story of battle and healing. Cutaneous tuberculosis presents itself in various forms, each with its own unique signature. Lupus vulgaris, the chronic saga. Appearance: chronic, progressive, reddish-brown plaques with scarring and possible atrophy. Common sites: face, especially cheeks, neck, and extremities. Symptoms: induration, ulceration, and possible secondary bacterial infections. Scrofuloderma, the subcutaneous tail. Appearance: subcutaneous nodules that ulcerate to form sinuses with caseous material. Common sites: neck from underlying lymphadenitis, axilla, groin. Symptoms: pain, swelling, and discharge from sinuses. Tuberculid, erythema induratum, the reactive chapter. Appearance: tender, nodular lesions usually on the lower legs, often with ulceration. Associated conditions, often linked with systemic tuberculosis. Orificial tuberculosis, venereal tuberculosis, the mucosal conflict. Appearance: ulcerative lesions at mucosal sites such as the genitals or mouth. Population: primarily affects individuals with immunosuppression or mucosal trauma. Miliary tuberculosis of the skin, the disseminated. Narrative: appearance: numerous small papules or pustules resembling miliary tuberculosis. Associated conditions: disseminated tuberculosis with systemic involvement. Acne variolosa, tuberculosis varicosa cutis, the hyperkeratotic episode. Appearance: wart-like lesions with a hyperkeratotic surface. Common sites: hands and arms, especially in individuals with a history of contact with tuberculosis patients. Navigating the clues. In our quest to identify the true nature of cutaneous tuberculosis, we become detectives, piecing together clues from history, physical examination, and laboratory findings. Clinical diagnosis. The art of observation. History: acute or chronic onset of symptoms, presence of purulent lesions, recent. Skin trauma, or underlying skin conditions. Physical examination: identification of characteristic lesions, their distribution, and the presence of systemic symptoms like fever. Laboratory diagnosis: the science behind the scenes. Microbiological studies: Ziehl-Neelsen stain detects acid-fast bacilli, AFB, though they may be sparse and difficult to visualize. Culture: the gold standard but time-consuming, up to 6 weeks. Requires specialized laboratories. PCR, polymerase chain reaction, rapid and sensitive method for detecting Mycobacterium tuberculosis DNA in skin lesions. Histopathology, biopsy, reveals granulomatous inflammation with caseation necrosis. Special stains, AFB stains, Ziehl-Neelsen, Phyt-Farico, to identify mycobacteria. Immunological tests, tuberculin skin test, TST positive, in most cases but not specific. Interferon gamma release assays, IGRAs more specific for TB infection. Radiological studies, chest X-ray, to identify concomitant pulmonary tuberculosis. Ultrasonography, for assessing underlying structures in cases like scrofuloderma. When to pursue laboratory tests, atypical presentations, when clinical features are not definitive. Immunocompromised patients, higher suspicion for atypical manifestations. Recurrent or chronic infections, to rule out underlying TB infection. Non-responding to conventional treatments, consider CTB in differential diagnosis. The healing journey. With diagnosis in hand, we transition to the therapeutic realm, crafting strategies that effectively combat the infection while preserving the patient's quality of life. General principles: the foundation of treatment, antimicrobial therapy, essential for eradicating the mycobacterial infection. Duration: longer than typical bacterial skin infections due to the slow-growing nature of mycobacteria. Compliance: critical to prevent resistance and relapse. Monitoring: regular follow-up to assess response and manage side effects. Standard anti-tuberculosis therapy. The treatment regimen for cutaneous tuberculosis generally follows the same principles as pulmonary TB. Adjusted for site-specific considerations. First-line anti-TB drugs. Isoniazid INH dose, 5 mg per kilogram daily, maximum 300 mg per day. Duration, 6 to 9 months. Rifampicin RIF dose, 10 mg per kilogram daily, maximum 600 mg per day. Duration, 6 to 9 months. Pyrazinamide PZA dose, 25 mg per kilogram daily, maximum 2000 mg per day. Duration, 2 months, during intensive phase. Ethambutol, EMB, dose, 15 mg per kilogram daily, maximum 1200 mg per day. Duration, 2 months. Treatment regimens. Category I regimen, new TB cases, intensive phase, 2 months of INH, RIF, PZA, and EMB daily. Continuation phase, 4 months of INH and RIF daily. Total duration, 6 months. Category 2 regimen, recurrent, relapse, or treatment failure, intensive phase, 2 months of INH, RIF, PZA, EMB, and streptomycin, optional, daily. Continuation phase, 1 month of INH, RIF, PZA, EMB daily. Extended phase, 5 months of INH and RIF daily. Total duration, 9 months. Category 3 regimen. Less severe new TB cases, intensive phase, 2 months of INH, RIF, and PZA daily. Continuation phase, 4 months of INH and RIF daily. Total duration, 6 months. Treatment adjustments. Drug-resistant TB. MRTB, multi-drug-resistant TB requires second-line drugs such as fluoroquinolones, e.g., levofloxacin, aminoglycosides, e.g., amikacin, or others based on sensitivity profiles. Extensively drug-resistant TB, XDR-TB requires even more specialized regimens with limited options. HIV co-infection, integration with ART. Initiate antiretroviral therapy alongside anti-TB drugs with careful management of potential drug-drug interactions. Adjunctive treatments. Surgical intervention. Debridement. For extensive skin lesions to remove necrotic tissue and reduce bacterial load. Incision and drainage. ID for abscesses or localized collections. Topical therapies. Topical INH. Occasionally used in addition to systemic therapy for localized lesions. Supportive care, nutritional support, to bolster the immune system. Management of comorbidities, such as diabetes or HIV. Monitoring and follow-up. Clinical assessment, regularly evaluate the resolution of skin lesions, reduction in symptoms, and overall improvement. Laboratory monitoring, liver function tests, due to hepatotoxicity risk with INH, RIF, and PZA. Visual acuity. With ethambutol therapy, adherence support, ensure patient compliance through counseling, directly observed therapy, DOT, or other adherence strategies. Side effect management, address any adverse effects promptly to prevent discontinuation of therapy. The dark twists. Like any gripping narrative, cutaneous tuberculosis carries the potential for severe complications if left unchecked. Systemic dissemination, leading to miliary tuberculosis or involvement of other organs. Fibrosis and scarring, permanent skin changes affecting cosmetic and functional aspects. Secondary infections, bacterial superinfection of skin lesions. Chronic inflammation, resulting in persistent lesions and potential disfigurement. Drug toxicity, hepatotoxicity, optic neuritis, peripheral neuropathy, etc., due to anti-TB medications. The heroic endeavors. Preventing cutaneous tuberculosis is akin to fortifying our defenses against recurring battles. Early detection and treatment. Prompt diagnosis and initiation of therapy to prevent spread and complications. Contact tracing. Identify and screen close contacts of infected individuals. Vaccination. BCG vaccine provides some protection against severe forms of TB, including CTB. Hygiene measures. Maintain good skin hygiene, especially in high-risk populations. Public health initiatives. Improve living conditions, reduce overcrowding, and enhance access to healthcare. Education. Inform patients about the importance of adherence to therapy and preventive measures to reduce transmission. Bringing theory to life. Patient profile. Age 35-year-old male. Presentation. Chronic, slowly enlarging plaque on the right forearm with central ulceration and scarring. History. History of pulmonary tuberculosis treated 2 years ago. Recent contact with a household member diagnosed with active TB. Clinical examination. Indurated, erythematous plaque with a well-defined border, central ulcer. And healing with scarring. Clinical approach. History and examination. The patient's history of pulmonary TB and recent exposure raises suspicion for CTB. The chronic plaque with central ulceration is characteristic of lupus vulgaris, a form of CTB. Diagnostic tests, biopsy, reveals granulomatous inflammation with caseation necrosis. AFB stain, positive for acid-fast bacilli. PCR, confirms presence of Mycobacterium tuberculosis DNA. Chest X-ray, normal, indicating isolated cutaneous involvement. Treatment plan, Category I anti-TB therapy, initiate INH, RIF, PZA, and EMB for a 2-month intensive phase, followed by INH and RIF for a 4-month continuation phase. Topical INH, apply to the lesion twice daily as adjunctive therapy. Follow-up, monthly clinical evaluations to monitor response and manage side effects. Outcome. After 2 months, reduction in lesion size and erythema. After 6 months, complete resolution of the plaque with minimal scarring. Follow-up, no recurrence observed at 1-year mark. Discussion. This case exemplifies the importance of integrating patient history, clinical presentation, and appropriate diagnostic testing to accurately identify CTB. The successful treatment underscores the efficacy of standard anti-TB regimens when adhered to diligently. The path forward. As we conclude our exploration of cutaneous tuberculosis, it's evident that this condition, while relatively uncommon, demands a high level of clinical acumen and a comprehensive approach to diagnosis and management. From recognizing its diverse clinical manifestations to employing targeted diagnostic strategies and implementing effective treatment protocols, our role as dermatologists is both critical and impactful. By embracing a holistic view, considering epidemiological factors, understanding the pathogen's cunning mechanisms, and committing to evidence-based therapeutic interventions, we can navigate the complexities of cutaneous tuberculosis with confidence and competence. Let us remain vigilant, proactive, and compassionate, ensuring that our patients not only recover but also thrive, free from the burdens of infection and its complications. Thank you for your attention and engagement. Your dedication to expanding your knowledge truly inspires us all. If you found this lecture insightful and enriching, please consider giving it a thumbs up and subscribing to our channel for more in-depth explorations into dermatological wonders. Together, let's continue our journey toward excellence in patient care and medical expertise.